Good afternoon, everyone. We have an exciting set of presentations for you during this session, and it's an opportunity to hear from our 6 tribal partners and that encompass Minnesota, North Dakota, and South Dakota, and they've been busy with their respective communities establishing their research offices, increasing awareness and support for research with community members, stakeholders, and tribal leaders. Today, it's my pleasure to introduce our tribal research partners and CRCAIH liaisons. From the Oglala Sioux tribe, Catherine Blindman, Fond du Lac Benda Chippewa, Cody Bassett and Jordan Mallory, Turtle Mountain Band of Chippewas, Anita Frederick, Kylie Kaplan, and Ashley Parisian, Sisseton Wapiton, Heather Larson, Spirit Lake, Bonita Moura, and the Rosebud Sioux tribe, Simone Bordeaux, was unable to stay and be with us today due to a family death in her family. So I'd like you to welcome our partners, and they will report updates in 3 areas of their research offices have been involved. To start, we will have each partner talk about their tribe's development of their research review board. And as you can see, there's no one way to put this important board together. Following, we will have move to presentations by 2 of our partners, Bonita Moura and Kylie Kaplan, who conducted community health assessments and their process, and there will be a brief discussion of data challenges by Anita Frederick. Including, we'll have a presentation by Cody Bassett, our tribal partner at Fond du Lac, who will share information about tribally conducted research, a topic all of our partners want to know more, and since many of them have a vision that their tribe will be able to move forward toward this goal. Shall we begin? Whichever you feel comfortable with.
Good afternoon, everyone. My name's Anita Frederick, and I'm from the Turtle Mountain Band of Chippewa Indians, and I'm also the president of Tribal Nations Research Group. And I know you've heard my name said a few times. I said, wow, I have to live up to a lot of discussion today. What we wanted to do is just kind of show a little bit about the differences in types of IRBs that we have amongst the CRCAIH partners. And our IRB in Belcourt, I'm gonna make sure I say that word right, but Russ isn't even here to hear me, so I could say Belcourt, because that's usually how we say it. But we are an external IRB who has partnered with our tribal government to oversee and manage, administer all the research that's being conducted within the Turtle Mountain community with the land, the people, the culture, anything that deals with any type of systemic data collection process. They have to come through our IRB. So it's not just human subject research. We do IRB review on everything. So some of the pros of that happening is, number one, like our tribal government doesn't have to worry about it, and they don't have to worry about being updated on the laws and the regulations, because we do that for them, and then we inform them of what the regulations are, what the rules are. Another big part of it is like we've pretty much taken on the financial burden of the process also. So, although we have our funding through CRCAIH, there is a lot of other expenses that come with that. And then also you have to think beyond what's going to happen in a year when we're, next August when CRCAIH's done with. So what's that next step? And we have the ability to be a nonprofit and secure some additional financial resources, in which we have already done, to help support this research agenda and the data center and all that work that's being done. Also, we have the ability to communicate amongst the community, I think, at a better level, because we can manage a website that we can easily change quickly and there's not this bureaucracy, there's not this committee that has to review it before it's placed on the website. I mean, if we have an update that needs to be put out there, we can just do it like that, you know. So it's like a 5-minute process. I need to really, we laugh sometimes because Kylie Kaplan is our website person, and she'll be like, Anita, can you check out the website to make sure it can go live, you know? So that's our process of, you know, ensuring that our updates are on the website and they're approved, is we just yell across the building. So our tribe basically does not support us in any way financially, except with the funds from CRCAIH, but basically we do the work and we just like invoice them for the work that we do. And we guide them in what needs to be done. If I was to say that there's a con in our process, and it's that maybe in the early on in the process, we needed to get more people in our community involved in what we were doing, but we were just so caught on, we need to get this done, we need to get this done, we need to get it rolling because all this research is coming through and nobody's reviewing it, and they're just doing whatever they want. So that's kind of where we're at. So if you have any questions, just let me know. I think, who's next? Anita?
Good afternoon, everyone. I hope you enjoyed the lunch. I know I did. My name is Anita Moura, and I am the Community Research Liaison here at Chicano Community College. I've been in that position since October 2014. The Tribal College had initially planned on working with our tribe to establish a one-stop shop for research. Unfortunately, we had a little hiccup, so we scaled it back. Now we're in the process of developing an institutional research review board, meaning the board will be operated and administered here, straight from the college. We will oversee projects that come directly to the college, are related directly to the college, to hopefully involve our student and our staff and our faculty in the research process itself. We are operating now under the approval by the Tribal College President and the Board of Regents. We're going to oversee all active research, specifically targeting the community college itself. We are also our intent is also to continue working to establish the working relationship with the tribe in building the research infrastructure and coordinating activities with them. The Community College IRB is registered under the OHRP. We intend to comply with all federal, state, and tribal rules and regulations. The board itself will review and approve all research applications specifically related to the tribal college community. The board shall conduct continuing reviews for any ongoing research related to the tribal college community. And right at this moment, we're continuing to work on our electronic submission process. So I guess that's it in a nutshell. Thank you.
Good afternoon. My name is Katie Blainman. I'm here for the Oglala Sioux Tribe Research Review Board, which had been formed in 2007. I do have our spokesperson with us here, Mr. John Haas over there. We are starting conversations about data management at this point. What else am I forgetting, John? We are still taking steps to develop a website where everybody can access our research review board information, and I think that's about it.
Good afternoon. Sorry, I'm sick, so I have all my Kleenexes with me. I'm Heather Larson. I'm from the Sister-Wapton Oyate on the Lake Traverse Reservation in South Dakota. Our boundaries are also in North Dakota as well, just a tiny bit. So I would like to explain our IRB is a tribal IRB, and our IRB is actually called the Local Research Review Board. We monitor and review all the research that's within the boundaries of the Lake Traverse Reservation, and this includes all of our tribal entities. So that would include our tribal college. They don't have their own separate IRB. We do monitor their research as well. Our other tribal schools, so even down to the beginning at the Head Start level and all the way up. And I just wanted to highlight on a couple other things. The authority, our tribal council made a resolution that gave the sole authority to our local research review board. They kind of wanted to pass that on, so it was something that they didn't have to, they really don't have the time to be reviewing all of the research requests that come in. I am a one-woman team so far, but we do have a lot of our members from our local research review board were able to come today, which is good. And they are key in helping our research infrastructure moving forward. So I just wanted to recognize them. Our review process, since we're so newly established, we do a full review of all the protocols that come in, and sometimes that is not human subjects research, but we do look at everything at this point. That may change in the future, but for now that we're happy with that and we accept it. Some things that make us unique is we're actually housed under our tribal education department, and we did have our research codes were passed this past summer, so it was made into law. Another thing that's unique about our code is through our THPO office, so the Tribal Historic Preservation Office under our tribe, they actually do their own review of any research that has to do with anything cultural. So that's one way that we are kind of exempt from that. And they're the expertise in that area, and we gladly pass that to them. The director of our THPO program is actually on our local research review board. So we still have that connection and that relationship with them. Our code also states that if there is research such as surveys or questionnaires done within our tribal departments or programs, they are also exempt from having to go through our review board. So those are a couple of ways that we are unique or maybe different from the other tribal partners. And then I wanted to touch on the types of research that we review, mainly on our reservation, is grant-funded research from outside people coming in. We are hoping in the future to be able to house our own tribally enrolled researcher to conduct all the research that we are wanting to happen in our community. But hopefully that won't be too far down the line. That's part of our strategic plan. And the other type of research that we mainly review is college students. So a lot of it is at the graduate level, but there are even some undergrads at our own tribal college that conducts some research, so that's good. So I guess one of the negatives would be that we are not conducting our own research. There's a huge need for that. Our office is fairly new, and so I get a lot of requests from our different departments and tribal entities asking, you know, well, we want to have this research done. Can you do it? And then I have to explain that we're not at that level or that stage right now. But hopefully that happens soon. And then another thing, excuse me, sorry. allergies are not fun. I wanted to touch on the relationships we have. So we have really great relationships right now with most of our community stakeholders. And I'm fairly new in the position. I started in August. I actually came from my tribal college. I was there for 5 years, so I really want to work on bridging that gap that we have with our tribal college. I know they are looking at possibly getting their own IRB, and I'm hoping that I could be, I can work with them on that process so that we just have a great relationship and a strong relationship with them that will continue on. But with our other stakeholders, like with our other tribal schools, we have a day school and then a tribal school, and our Head Start programs, we have really great relationships. Also with our tribal health program, things are going really good. I want to do some more outreach in the future to our 7 districts and just kind of keep them all involved in knowing what's going on with our research office. It's something I haven't been able to do yet. I'm hoping this summer. And like I said, the tribal college is a really big one where I need to bridge that gap. So those are all the things I had. Thank you.
Hello everybody, thanks for having me. I'm Cody Bassett. I am one of the research specialists at Fond du Lac Human Services Division. I am also the chairman of our institutional review board. A little backstory behind that: when I came on board in December 2013, that was one of my primary tasks, was to essentially rewrite our entire policy and procedure manual, as well as put together a board, get it in line for registration with OHRP and getting an FWA. So since, it's been about 1.5 years since it's been functional. In that time, it's been sort of a trial run. We mostly review internal research. So the study I'll be talking about in a little bit, anything we've done in partnership with the Minnesota Department of Health or who else? Regardless. So that's the primary research we review. Us and our partners. We're kind of unique and we don't really cover the tribe specifically, because there are research projects that happen with the environmental division and other groups. We don't really cover that. It's all health related in the medical field or behavioral health, substance and drug abuse. And we're getting ready to register with OHRP and get an FWA, hopefully within the next 4 months. And also as a backstory, so I came on, I mentioned earlier, I had to rewrite the policies and procedures. We've actually had an IRB since 1995. It's never been registered though, and it was, for most reasons, to get one. It's just another way to have a voice and another level of control and review in research. So I think that's about it. Thank you.
Sorry. I just wanted to mention about Rosebud. Rosebud is our 6th tribe that has joined the partnership at CRCAIH. And I wanted to say that they're in the planning stages of working with their tribal leadership in developing the ordinances and the requirements and the wording in terms of establishing their IRB, and also in the development of which way or what type of IRB that they will have developed. So I'd like to say too that Simone is a great person to work with. And she comes with a lot of talent and experience working with, as a navigator with the cancer program with her tribe. And so we look forward to her, their RRB to be developed and moving forward as well. So thank you on that. We'll now move on to our community health assessment presentations. And Anita, could you join at the start for us?
And then I just get to click that one, and that one. Okay. Thank you, Victoria. I appreciate the introduction. First of all, I'd like to say thank you to our CRCA partners for providing this opportunity for us to showcase our programs, our projects. I appreciate that. I also want to extend a thank you to the tribal partners who have been very beneficial, very helpful to me since I began my employment here at the college in 2014. We really work together as a team, as a crew. We help each other out. We share documentation. It's been a wonderful experience. Thank you. One of the things that I did over the last 12, 13, almost 13 months, because we started the planning process for our community health. Community needs assessment was in December of 2014. We first started talking about it. And the initial intent was to meet a program requirement. And then we had our tribal leadership and our college president bring it to the table and broaden the scope of the project itself. So then we ended up with coming out with a comprehensive community needs assessment for the Spirit Lake tribe. The initial, like I said, the planning started in December of 2014. We talked about who was going to be the composition of the work group. Well, as I initially said, one of the programs, we were trying to meet one of the program requirements, and one of those requirements was they needed to do a community needs assessment. So we just expanded on that. So the program that needed that to meet that requirement was one of the lead agencies that we initiated, and we got a lot of help from them, and that was our Head Start program. We looked at other partners that would be available, and of course I was part of that process. Being on the CRCA project, we had wonderful assistance from our CRCA team, the cores. We had tribal partners come on board who were interested in the planning phase of it also. And you look at, I'm looking at that, I don't know, I think it'd be easier, but then I also don't want to ignore the audience, so it's kind of hard. The stakeholders were critical to the success of this community needs assessment project because, again, meeting program requirements, meeting program reporting requirements, and for some, meeting program goals and objectives in general. The roles of the teams, how was the roles of the team members identified? Well, we didn't make the assignment. We just asked the team members. There ended up being about 15 team members. We just asked them what role they would like to play, and many of them said interviewers. We had 2 individuals who said they would take on the lead role, so we had a project director who took on the lead role, and I was kind of like the coordinator. I helped facilitate the meetings and make the arrangements and whatever the case may be. How the team developed the size, it was just a matter of collaboration. People really wanting this to happen, and it happened. We started out having meetings. I believe in January we started our meetings. We'd have a meeting at least twice a week. We ended up coming up with, I think it was a 15-page interview tool. We got a lot of support and help. There's critters crawling around here. The Fond du Lac partners really helped us out. They shared one of their survey tools, and so we just took that and ran with it, expanded on it, and so again, thank you for that help. The assessment process itself, one of the things we looked at is what is the benefit of conducting such an effort within our community? Well, we want new information. A lot of programs have information, but it's old data. Even looking at the census in general, a lot of the data came from 2010. So what can we do to improve that? Provide new data stats, meet program requirement, collaboration efforts within our community, engage community members, and future planning process. The planning process itself, what I saw it as was we walked through our communities in establishing this assessment process. We provide a snapshot of policy. We talked about the systems. We talked about environmental changes. We talked about strategies. We talked about assets and needs. We frame and understand the current status of the community health, and it allows communities to track progress so incremental changes can be noted. It'd be wonderful if we could have facilities throughout the reservation as in the picture. Learning opportunities for our community to grow. What do we have available? The top picture is the community college students were putting bricks, building bricks. And it's, I believe it's going to be an art, a completed art project that's going to be shown at UND Museum of Art. The second photograph is just doing some of our cultural heritage work, quilt making, cutting stars or triangles or whatever the case. These both are here at the college. These are available for not only the students, they're available for the community in general. Photo voice, purpose, the strengths and resources. Picture an area. We thought of picture an area in our community that we deemed appropriate and highlight a reason why. Areas for improvement. Picture an area that may be deemed unacceptable and highlight the reasons why. Difficult to access, solid waste, lack of pedestrian crossing. Well, the first thing I thought of when I got pictures was the picture of our children. Our children are our strength. They're our resources. This is what we're doing this year. What's going to evolve from this community assessment is going to be, hopefully, what I see is improvements for building capacity for our children. Building on what we have now, the strengths and resources for them that will benefit them in the future. An area improvement, over the last couple of weeks we've been talking about cleaning up our communities, and we're trying to engage all the communities in being part of this, because what you see there, it affects those children in that picture above tremendously. Data gathering, success stories, challenges, and anecdotes from the process. The overall implementation of the community needs assessment was successful due to, of course, the initial planning, the collaboration of the work group, the sites for all the sessions. And the reason I'm saying the sites was because it wasn't held in one specific area. We had a session here, and we had sessions scattered throughout the reservation. And it wasn't just one session, it was two sessions. It was a morning session and an evening session. Meals were provided at each location. Individuals were very respectful during the sessions. We wanted to accommodate our working parents, our working families. We engaged the children that attended with their parents. We had childcare available. We had meals provided. We had one of the businesses in Devil's Lake who we work very closely with was very willing to help us out and provide our afternoon and evening meal. So we appreciated that. Transportation was a concern, and again, the work group decided that's why we went out to the community as opposed to staying in one location. The method design was a cross-sectional anonymous survey. The instrument based on previous Chandesca Chicano Community College Health Surveys from 2005, 9, 10, and 13. The Spirit Lake Comprehensive Community Assessment 2015, we revised it, and we used information from the 2012 Burfus Housing and Child Care. Data collection interviews. We initiated the first round of interviews with the Head Start parents in May before the classrooms the program shut down for the summer. We sent out 418 flyers prior to the July interview week. We had face-to-face interviews recorded electronically on iPads. We had 15 iPads available during the sessions. And we provided an incentive of $25 to Walmart to the participants. The sample, we ended up having 258 residents of the reservation complete the survey. 70% were female, average age 40, ages ranging from 16 to 89. 80% lived in the community for 18 plus years. 46 never married, 34% married, and member or of unmarried couple. 28% less of high school degree. 51% had a high school degree. 22% had a college degree, which is good information for the college. 38% had an individual income under $5,000, 73% under $20,000. Average number of people per family was 4.86. Number of people ranging from 0 to 19 people per family. Community assets and priorities. What are our key assets? External resources, funding from federal agencies, funding from private agencies, funding from philanthropy, people. You know, what is our resources as far as our people? What expertise do we have in our community? We have local people who are very knowledgeable about our culture, about our history, and then we have people who are very have expertise in the different sciences, the different health, and different education. Economic development, what do we got here now? What can we look forward in the future? And the top priority areas for our community action plan, what we hope to work on, the number 1 item was child safety. The number 2 item was housing, and number 3 was employment. Number 2 and number 3 were 2 items that were identified in 2008 from our strategic plan. Next steps. We're going to disseminate. If you attended the poster session, we did have a poster out there, and I believe President Lindquist is going to provide a snapshot tomorrow during the tribal symposium. The short-term goal, collection of new data and stats by the grassroots organizations. Long-term, collection of ongoing data and stats that promote and support changes and improvements for our community. Developing the community action plan. Lessons learned, collaboration makes things happen. Improvements for continuing review, one-stop point for review and continuing comments, support for ongoing efforts, time, input, and resources. Thank you.
Hello everybody, I'm Kylie Kaplan. I'm from Tribal Nations Research Group. I am Program Director of Community Innovation through a Bush Foundation grant. And I guess Anita and the board hired me back in July, and she made me hit the ground running. So in October, Stephanie J from back home, she's from Tribal Master Health, Wyatt, wherever he's at, and Victoria went to Albuquerque, and I was trained very well in community health assessments. So when I came back with an 18-month plan, Anita told me, no, it's got to be 9 months. So we basically went to go this big to this big. So it was pretty exciting. So why does TNBCI need a community health needs assessment? For the simple fact that we have never done our own. TNBCI has never conducted their own community health assessment. That's not saying we've never had one done, it's just never been done by our people. Basically what we plan to do is take primary and secondary data, put it all together, and establish baseline information about our people that is accurate to our community. That way we can go on, make data-driven decisions for funding for tribal government or tribal programs. We get to prioritize our health concerns, and then we can develop a plan of action to meet those concerns in the end. Like Anita stated, there's a lot of potential use and benefits of a community health assessment. Health services planning, program development, funding allocation, public health accreditation, and also too is looking at our areas of concern, but not only that, our areas of strength. I'm not a firm believer in always looking at the negative, but always looking at the positive also, because you gotta be proud of something, and why not your strength? So the way we kicked off our community health assessment is we wanted to build a buy-in first. So we put our little heads together and we decided to have a data conference. And basically what Anita did with all her expertise was present all the data that has been reported about TMBCI, and we invited all these people in the blue from our community. From the road department, the BIE schools, the BIA, the college, all of our tribal health programs, they were all invited. And they got to see the data that Anita put up, and we got to kind of see, like, well, that doesn't look right. You know, they got to see that. So that was how we were creating our buy-in of this community health assessment, because usually people look and they say, well, this has already been done. Why are we doing this again? So we wanted to put a strong foot forward and say, this is why we're doing this as a people, as TMBCI. And with that being said, we moved into the second day, and like I said, Anita brought in our buy-in. We started explaining our community health assessment. So that way we could kind of convince them to just be a part of the coalition we were planning on building. So the next day, after we explained what the whole community health assessment is, we explained to them what a coalition is and what our coalition would be asking of them. They would help develop the community health assessment in general. They would, right now, actually, we are submitting our survey and our community health assessment plan to our IRB, and they built that survey from basically the ground up. It took us about 4 months to build. And we took questions from, different sources like YRBS, PRAMS, North Dakota Kid Count, all different types of sources, but we made them culturally appropriate so people from our community can understand what they're answering. So our coalition were asked to do that. They were asked to build the methodology and how we go about doing it. Marketing, we hit the ground with marketing. We're with our newspaper, with our radio, with our Facebook, with our website. We're anything that we can get our hands on, we're hitting it. The coalition is also going to be involved in collecting information. A lot of the people in that blue slide you see in there, they're all tribal program directors, and what we want from them is their data, basically. So they're going to help us build that secondary database by handing us over whatever data they have. And then in the end, the fun part, we get to build that community health strategic plan and then disseminate the information out to the community. So we explained all of this to all these people. And in the end, we ended up having a 15-member coalition from all of that. And they all signed a letter of commitment stating that they would be at a monthly meeting and converse through email, basically constantly since December. And they've all been great, and they've all participated amazingly, and I'm very proud of what they've become. So moving on, we also developed a purpose. We all have a reason for doing things, so we put it down on paper. To promote health equity for enrolled members of TMBCI residing in or adjacent to the TMBCI reservation through health promotion and health disease prevention. And we say in or adjacent to is because Belcourt is the reservation, but we also have people in Dunseith, which is not too far away, Rolette, Rolla, St. John. We're everywhere in our county, but the reservation is 6 by 12, so we're not all in one little spot. So we make sure that we're going to hit everybody in those towns also. So this is our big plan. This is what we went to. Our design, we built the community health survey, and like I said, that was a grueling process. We finally made the last changes to it, and our coalition was very much hands-on with that. They helped build the methodology. We decided to keep this a convenient survey just because of the time frame that we have. So we're going to be hitting up high traffic locations such as our casino, our post office, IHS. Hopefully the schools, we could get there before they're out of school. And then we decided on a sample size. And I have to say, we feel like we're shooting for the moon on this just because you got to stay positive, right? Rolette County has a population of about 14,600, I think the census estimated. And about 76 of those identified as American Indian. 76%, sorry. Thank you. Thank God you're here. So, like you said, 76% identified as American Indian. We were told that we need to reach at least 2,500 to 5,000 people, which isn't hard with Facebook because, like they say back home, if you want to know something, check Facebook out. So we are constantly on Facebook. The newspaper, radio, we're everywhere to reach these people. And we're told we only need about 500 surveys back. But Anita, like I said, she made my 18-month plan go to 9 months. She told me, let's shoot for 2,000. So I'm staying positive, and we're going to try to do that, even if I have to go door to door. Marketing. Our marketing is, we had some help with American Indian Health, Public Health Research Center from Fargo, and they helped us with a marketing plan. And Hannibal actually is designing some flyers for us. And oh, she's got them to disseminate to the community. So she just hit up the populations. She actually came down and interviewed people and from all walks of life to see what they would like to see in marketing. So we have that down. We're hoping that really helps us out there. Cooperation. Our cooperation has been awesome since we've started. Tribal Council has been behind us 100%. Tribal programs, they all know this. The schools, we have a huge school system and they're behind us. But to go into everything, when you go through the IRB, you need letters of support. So what we ask from the Tribal Council is a tribal resolution that blankets all tribal programs, tribal enterprises, so that we don't have to go through every person and get a letter of support. Also, if you're not under the tribal program or Tribal Council, let's say jurisdiction, we did get letters of support. Like I said, administering in high traffic areas, tribal programs, and we're also doing focus groups, probably like 4, just to see what people consider how healthy our community is. And then the fun part, after it's all done, we want to triangulate all that data, all that qualitative, quantitative data, and put it all together so we have a more comprehensive community health assessment. And then we're also going to look back through YRBS, BRFIS, PRAMS, to be able to do a comparative study on everything that we put together. We're in the middle of it, so we don't have any data like Anita has, but we hope to have all those numbers like she does soon. So now what? We build a community health profile, we address our needs and concerns, we develop our strategic plan, and we get to decide what our future holds for our community. That's it. Thank you.
Go back a slide here. See that cute little girl down there? That's her daughter. And what's really great is that Kylie's daughter has been fortunate to learn both of our cultures in our community. We have a Métis culture, our Michif culture, and our Ojibwe culture, our Chippewa culture. And Kylie's daughter is a national jigger. She's won national awards, and she's also a very good jingle dress dancer. So, right? Jingle dress, yes. So we're proud of that little girl. She's going to be our poster child. I'm going to really quickly, because I know we're behind on time, so I'm going to go through the data. So how can we apply all this data we collect in our tribal communities, and how is it, and why is it so very important? And I know you heard all about it today, and so we're going to try to make this as short and sweet as we can. Tribal Nations Research Group has a mission, and it's basically all we want to do is improve the quality of life for all of our tribal members through culturally competent, custom-fit research. And this mission statement was designed and developed, and it's reviewed quite often. We spend 4 hours of an 8-hour board meeting reviewing this mission statement. Almost a report meeting, no, I'm just joking. 2 days before Christmas, they decided we want to review it, and one of our board of directors, Cardi Manette, he sat there and he's like, it doesn't fit, something's not there. So we looked at it, and we looked at it, and reread it, and we reread it, and we thought, we'll put this word here, we'll put this word here. 4 hours later, we were back to the same mission statement. So I think we're good. Our purpose is just basically how can we serve our community? and how can we use data to make some decisions. That's basically what all that says right there. Promote public and private economic development. A big part of what we do is we try to promote that in our community, and we always want to be positive in what we do. We're not saying that the data has to be good or the results have to be good, but when we're reporting those results, let's report them and say, okay, we're going to fix this how, we're going to do a plan how. So that's what we really thrive for at Tribal Nations Research Group. And our goal when we first started this process was to develop a statutory process to review, govern, maintain, and house all research, collection, database, publication undertaken within the Turtle Mountain community. So basically, anything published, coming out of research, will come through the Tribal Nations, the IRB. All the data is housed in our data center in which Tribal Nations Research Group manages. So that's kind of how we work. Our relationship with the tribe is that we establish this process for them, and we used a lot of documents that were out there. Believe me, for 2 months I read and I coded, and I'll tell you those dissertation writing skills really came out because I'm coding yellow, I'm coding pink, I'm coding orange. I have this spreadsheet going, and it was like you got lost in all the information. So I'm like, okay, here's this Indigenous Research Protection Act, and it does it all. It tells us everything we need to know in there. So let's just adapt it and change it to meet Turtle Mountain's needs, and that's what we did. Why, again, reinvent the wheel? Why spend our minimal resources to reinvent the wheel? We established and managed the TNBC Research Department, which is the Tribal Research Review Board and the Research Catalog. Everything else Tribal Nations Research Group does for the sake of Tribal Nations Research Group and our tribal community. And then we have the data center and repository, which will become the official reporting entity of the tribe. So we'll give our tribal government a nice little report every quarter and say, here's the new numbers, here's the new updates, here's things on housing, energy, environment, all those great, fancy stuff. I know this morning Cynthia mentioned about putting it to practice. Well, Turtle Mountain, we're doing that. We're getting to where we're putting it to practice. We're at that point where we can say, no, we don't really need this right now because it's not a priority in our community. And it really is not going to be a benefit to our community. It might affect one tribal member. We're looking at affecting 50, 100, 200, 1,000. We're looking to make a difference. We're looking to put that intervention in place. That's what we need for our community now. Okay, so why did we do this? Well, we're doing all this data because we want to establish our own benchmarks. Kylie mentioned when we did the data retreat that when we were looking at numbers, we would have Rolette County has 200 births this year, but Turtle Mountain has 221. Well, Turtle Mountain's dead center, Rolette County. So which number's right? Then this organization was citing the other organization. So it's like, okay, they say they got this information from this one the same year, but the numbers don't jive. So what number's right? So we're going to create our own numbers. We're going to establish those numbers. We're going to establish our own data so we can say this is what is a true picture of Turtle Mountain. We want to change for our community. We don't want to just keep doing the same things over and over and over again. We want to increase communication amongst our tribal members. We talk about, health disparities. A lot of Indian people don't even know what a health disparity is. Our social determinant of health, that's the big one. I go around asking, well, do you know what a social determinant of health is? Again, we use the words that they don't understand. Well, no, what is it? Well, it's like we're not eating healthy. We don't exercise properly. We smoke. We use alcohol. We don't sleep enough. Those are all, health issues. And then, you got 4 families living in one household. You don't go and have your intervention or your yearly checkups and all those types of things. All that is a social issue. So those are kind of your issues that we need to deal with in the community. So, and then this way we're going to have everybody in our community working towards a common set of goals, because right now we don't communicate. Okay, so I know I'm getting the white flag. So we're doing this in 2 phases. The first phase was that we're going to do the research review board. We went back and got all the old research we could find, all the old resolutions, and now we're getting back data from those. And you remember Russ said this morning that he's seen an old report. You guys would be so interested to see this report because it's pretty much the tribal IRB toolkit. It's really interesting. I get this nice little pamphlet in the mail, and it talks about how do you work with tribal communities. You know, what should you consider when going into a tribal community? That's a lot of what this booklet was, and it was done in 2004. If we would have had our tribal data center already up and running way back then, this report would have been in there. It would have been archived, and we wouldn't have had to take 2 years to develop a process that was already done. So again, we spent resources we didn't have to spend because we are, as tribal governments, didn't keep good records, and a lot of times they don't want to share because they've been taken to the cleaners so many times they don't want to give out the data. But they're going to give them to me because they trust me with them, and I'll watch them with my dear life. We're going to track the research results. So we're keywording research. So we have 5 projects on diabetes, and we have 3 on heart disease, and we have all these environmental studies. And okay, so when a researcher comes to us, we're going to say, well, that's already been done. Here's the results, and here's the findings from the other people because it didn't get published. So you might want to take a look at that and then maybe do something a little bit different because they have recommendations for further research in here. So let's use those recommendations for further research. We catalog past research, that's where we're at. We collect a list of secondary data sources, so that's where we're going to, like the BRFIS, the census, IHS. We have a bunch of IHS reports that we're working through. You know, just old program evaluation reports that had data in them. Some data that was collected during the Northwest Area Foundation when we received our venture status. So kind of those types of things is how we're building off of. Phase 2 this is the huge project. So we're taking and we're evaluating the tribe's technology. We're looking at their technology infrastructure and how could we speak to each other quickly. So, and how could we provide services quickly? So say somebody goes to the tobacco prevention program, or somebody goes to the maternal and child health program and they say, you know, well, do you smoke? Yes. Do you want to quit smoking? Yes. So you check the little box, and automatically the tobacco prevention program will get a referral that this lady would like to quit smoking. So it's a point of contact for the tobacco prevention program. So again, do you want to go to college? Yes, I do. I just don't know how to start. I don't know where to start at. So boom, it'll go to the recruitment people at Turtle Mountain Community College, and it'll work with them to say, hey, you know, this lady like to go to college, here's some information. And so that's what we're trying to do in our community. That's the work we're working on right now. We have a grant into HRSA, hopefully it's funded, to do the whole evaluation piece and see how we need to upgrade the technology and you know, give us some time to write a proposal to get some funding for that technology system, okay? And then all the people on that second tier can be involved in that. We'll inform, you know, we're looking at policy. How can we change policy to meet the needs of our people? We're looking at communication. So do we have a communication plan? You know what, if we had a, what do you call that? Like a really bad illness, like Ebola outbreak in Turtle Mountain, we would know what to do. We'd be all infected before we even knew it because we don't have an emergency plan in place for it. And if we do, it hasn't been communicated to our community. And then, you know, just looking at other resources, they'll all be put in a data warehouse, they'll be analyzed, we'll find those patterns, and we'll communicate it to the tribal members in the community, outside the community, tribal leadership, and community services and programs to inform their work in all those areas. The results will be a research database, demographic information that we trust, you know, that and we can build off of. Data sovereignty. We no longer have to go to all these organizations to get our data because we're the one. They're going to be coming to us and say, hey, Turtle Mountain has this community health assessment and you guys have like 2,000 survey, you know, people that you surveyed. That's really valuable data. Can we help you? Can we get a piece of that data? And yeah, we'll share it. Better understanding of our community and the needs of our community, and most importantly, an educated and informed community at every level. We'll educate them through, flyers, through newspaper articles, through the Kia radio station, and it's really great because all these people are giving us all this work, all this marketing for free because they know how important it is. So that's what happens. So items to remember: when collecting data in tribal communities, always have respect for the community, the people, their culture, and their lands. Tribal reservation communities have qualified individuals available to help you understand the data needs, so just reach out to them. Find out who they are. If you collect the data, do something with it. Inform a policy change. Informed leaders are informed the community somehow. And if you want to learn more about us, you can check out our website. It's very comprehensive. Thank you.
Hello again. How am I doing on time? -5? I'm kidding. All right, well, I'm going to try and be brief here. So, hello, thanks again for having me. Let's see. So, since I started at Fond du Lac in 2013, December, we've been working on the opiate crisis in Indian country. And while most of the data is FDL specific, I'd imagine this is touching just about everybody's families in Indian country at this point. We have an extremely disproportionate effect on this, or involvement. So, just a little background what spurred this on. So even before I started, in 2010, neonatal abstinence syndrome was reported to have a sort of a 40% rate in our community, and that's associated with substance and drug abuse while pregnant. So these babies are born with withdrawal symptoms manifesting. And you can see, I'm going to try not to read all these slides to you, but overall over 20% of all Minnesota NAS newborns are American Indian. And let's see, a great majority, over 75% I believe, are born in greater Minnesota, which is northeastern Minnesota, where Fond du Lac is located. And you can see these striking, horrible numbers that came from Medicaid claims data that the Department of Health and Human Services brought to our attention. So our response to this was we needed to further define this because there was this culture of ignorance that was going on. People were saying this is a problem, but it's not what we thought it was. And, well, we knew they were wrong, but we didn't have any hard data to support it. Diversion of methadone and Suboxone, the widespread diversion, it's happening, and nobody was accepting it. It was just incompetent, actually. I might be able to beat you on controversy today. So we had community specialists. We thought, what makes us unique? Our communities, despite whatever problems may be present, we're still very strongly tied to one another through family and friendship. So why not use that to our advantage? We had community specialists that we got them, we trained them to administer this survey, and they identified current and former users in the community to survey. So it's a very select population, and we did select people, so it's not truly random. But for our purpose, we felt it was justified. So everybody who participated had a $25 gift card. They took the survey. We had 62. We collected all this data in about a month. So we were I was really impressed with how fast we could get it. And it was 100% FDL conducted. Nobody else was really involved. It was just us, and it was completely legitimate too. It went through our IRB. We were extremely careful. Our precautions were quite intense. We have an outpatient facility that we provided, that we offered up any sort of service or whatever at it to anybody who participated. So, continuing on, a little background about methadone. This is the maintenance therapy drug that is considered the standard for if you want to get off of heroin or you want to quit abusing opiates, you go on methadone. The issue with methadone, though, is when you come off of it, withdrawals last longer and they're worse. So what a great drug to have people maintain on, because withdrawals suck and getting clean is even worse. More difficult, too. I've actually met a few people who say they'd rather go cold turkey off of heroin as opposed to methadone. But the big take home from this one is that, as you can see, all the sources, everybody had not everybody, over 80% had methadone, but only, so that's 52 out of 62 of our participants had methadone, but only 20 had ever been a methadone client. And the only way to really get methadone is to be a client. Sometimes you can get it for pain, but that's very rare and not the best thing. But anybody who did get it, 75%, it was freely given to them. So, yeah, it's sort of comparable to getting your first beer from your dad or your uncle or whoever. But that is consistent throughout the whole thing. It doesn't necessarily go to a selling market. It's freely given and exchanged in households and family members or whatever the social structure is. And in this, I love to talk about the step ladder, because if you want to talk about intervention and prevention for the at-risk group, which we sampled, you can see it right here. Yeah, I have it in percentiles, and you can see the alcohol use and marijuana use pretty much start at the same time, and they follow each other pretty consistently. And then you have your other illicit drugs, followed by opiate prescriptions, and they're pretty evenly spaced throughout. Every 2 years you get something new. And then you have methadone, and as I just talked about in the previous slide, most people get that illicitly as well. Alright, and I kind of jump around because we have a much longer presentation that we do, but for the sake of time I had to cut quite a few slides, so it gets a little wonky. Let's see. So this just highlights all the dangerous mixtures that we were told doesn't happen with people who are in methadone maintenance therapy. And the extremely high dosage, 100 milligrams is right on the cusp of bordering what I would consider malpractice. I think the federal guidelines are never go over 120 when it comes to methadone maintenance therapy, but there are people who had up to 200, and we didn't have any in our sample, but there are people who do up to 300 milligrams. Which is pretty dangerous. And then you see all the dangerous stuff that goes along. So people are being prescribed opioids while they're in methadone maintenance therapy for chronic pain. You see them taking benzodiazepines, which are antidepressants, very commonly associated with chronic pain. Depression is. So those two drugs are probably what is most responsible for overdoses. People take them, and it slows down their central nervous system, and they go to sleep, and they never wake up. It's not like Pulp Fiction where people overdose and it gets violent. So, up next, take-home doses are earned in methadone maintenance therapy after you prove that you're a reliable client or a trustworthy client. So for our sample, 65% of people who received take-home doses reported diverting them. And this also plays into earlier where, while only 20 people were clients, 52 had methadone outside. They're getting liquid methadone that people take home as doses to have over the weekend or even over a week. And it's pretty easy to get more take-home methadone, unfortunately. All you have to say is, my cravings are bad, I need more, and they'll usually up the dosage. And so you take it home and disperse it, or give it to whoever, or trade it for whatever you want more. It all changes, and we've heard quite a few different stories. So the outcomes are pretty good, actually, in the large scale. So we did expose what we wanted to. We were finally able to say, this is what's happening. You need to do something about it. So all the tribes in Minnesota, we drafted up 6 resolutions that demanded we do something about it, or that they do something about it. So now the state will be investigating this further in corrections and other avenues, and they're also going to be working with us. This research is being used to shape and drive policy in the drug treatment community, and it's hopefully going to bring about an increase in accountability, because right now there isn't much when it comes to drug treatment and efficacy and safety for clients. So, and that's my contact info if anybody wants to talk to me further, because there's a lot more data.